So when we look at the PED decision making for individuals with PCOS, you have to understand that the unwanted effects, the androgenic effects, this is the result, it's the product of the androgen binding to the androgen receptor. So women with PCOS, even though with most women, with biologically born women, we have two X chromosomes. Now, one is usually turned on, the other is turned off. But with women with PCOS, this tends to be skewed. When we look at your circulating androgens, you have your testosterone, you have your DHEA, your DHT. Androgens alone, even like weak androgens, they can bind and then cause that gene transcription, which then that's where you see that secondary sexual characteristic like deepening of the voice, androgenic alopecia, darker facial hair growth, some, prevalence of acne. And in some women, like we can address these by changing the sensitivity of the receptor and changing the density of the receptor. But really, after that, if you're trying to prevent these side effects, you want a combination of less synthesis or more metabolism or less binding to the receptor. So really, if you're trying to prevent these side effects, you want some kind of combination that is going to promote less synthesis or more metabolism and less binding to the receptor. And once we start talking about pharmacology that reduces that androgenic, that burden, you really don't want that at the time that you're trying to conceive or you're trying to promote fertility. So example of something like finasteride, dutasteride, these are known teratogens, and you don't want to be taking these because they can cause, particularly in the male fetus, changes to genital development. Now, these are ones that I think a lot of women will kind of put in place or be told, hey, recommended, this is something that I would begin, on account of those androgenic side effects, specifically the hair loss. But what you have to remember is that they do have peripheral effects, and this can present in terms of lower libido or effects on both estradiol and progesterone. Another one that we're looking at is spironolactone, which is commonly given alongside metformin. And there's mixed data to support its efficacy and if there's an alternative or if the benefits actually outweigh the potential risk. So it's one that I personally would say like that really any kind of diuretic or adjacent diuretic, they can carry a bit of a side effect because, yes, it's going to modulate blood pressure, but when we look at ones that are potassium sparing, this is going to be something that needs to be closely evaluated, even though, yes, it will offer more of an androgen antagonistic like effect. When we start digging into what this looks like on a day-to-day basis, considering whether or not that effect is beneficial enough to outweigh the risk of now a hyperkalemic state or even the diuresis that is going to accompany regular administration. Now, when we start looking at the hair growth, like terminal hair growth, for example, so on the chin, on the upper lip, there are topical agents and you can certainly go with a treatment like a laser hair removal. And these things, they can be helpful, yet you have to understand that like once the hair has set in, like on the jaw or the chin, like removing that mechanically or destroying that cell, that's really the best it's going to get. And then past that, it's about promoting a regimen where it's unlikely to reoccur, which usually is the best way to go about it. But in the case of someone who has PCOS, is already sensitive at the receptor site as a whole, who does plan to use any kind of AAS, this is certainly something to consider and not necessarily look at as an indication that you're doing something wrong, but rather this is a consequence of the consistent and repeated exposure to that drug. Yes, the best way that I would recommend going about preventing and mitigating the risk of any of these side effects with or without PCOS is to minimize their exposure and to reduce it only to times that are absolutely necessary. But even with that, I think understanding that no degree of anabolic use is technically going to be risk-free. All of them do carry that same risk on account that Just as we take on the hope and the promise of the anabolism, the androgenic effects are as equally likely, even if we're looking at someone who is more sensitive or does have a higher likelihood that they will present with these unwanted effects. As far as different medications, anti-androgens, yeah, I mean, like, you're going to see if you go to different providers that they're often just given, but when we look, like, just given alongside, hopefully the idea would be the encouragement for the athlete to remove any kind of AAS or any kind of hormonal therapy. But I've also seen it at times given alongside hormonal therapy, which I personally think is a little problematic, because it's like, okay, if in this case, like, I mean, I'm talking about a specific instance where the individual, they were not diagnosed PCOS. They struggled with acne previously. They were put on HRT at a starting dose of 20 milligrams. It was injectable. So, I mean, like, it was like the best form at which they could receive the drug, the hormone. But the individual, her circulating serum testosterone levels were very high. Like, they were absolutely super physiological. Yet, instead of bringing the dose down, the provider opted to put in spironolactone on a regular basis. And that was just the play. And I mean, like, it was a young girl. She was a young girl. I mean, it was something that personally I would question, like, is this really the best route of, or sorry, really the best intervention to mitigate those signs of acne? Or would it be favorable to just lower the dose as a whole?